Okay, so I'm provided with a spot image of barium swallow, lateral projection, and I can see a large radio opacity in the mid esophagus, which is eccentric and spanning a large course with the subtle haziness of the mucosa. So I'm thinking of a giant ulcer like cytomegalovirus, the CMV esophagitis. Um, I cannot see any mucosal irregularity other than this large opacity. There is no contrast leak. There is no significant holdup of the contrast. So next, I would like to correlate my findings with the history of the patient.
Okay, let me ask you, you mentioned CMV as a differential. Just comment a bit more about, I mean, you've mentioned there's this large area of ulceration. I completely agree with you. Talk to me a bit more about this ulceration. What do you think about it?
Okay. It's in the mid-esophagus.
Yeah.
It has it's giving a shaggy border sign posteriorly. Not shaggy, but there is some hazy border. So yeah, there is some mucosal projections beyond the normal luminal contours of the esophagus.
It's kind of extending sort of beyond the contour, isn't it?
Yes.
So why do we get that appearance?
When we get them in pseudomembranous diverticulitis when they what was that?
Yeah. Okay, so I guess what I'm saying is that the barium is projecting beyond the contour of the wall, as you rightly pointed out. But do you think it's going a small way into the wall, or do you think it's going quite a long way into the wall?
I would say it's going a bit long way. I'm thinking of the glands that get filled up with barium.
Yeah, I agree with you. I think the barium is going quite deep into the wall, isn't it? Yeah. Yes. Like for instance, this area here, yeah? You see the edge of that barium is kind of sticking all the way out here. So if I tell you that there are deep ulcers, does that change your differential?
Then it would be
anything else you can think of?
Then it would be more in favor of inflammatory ulcers.
Yep, such as?
Any corrosive intake?
Yes, yeah, absolutely. Okay, so if you were going to give me one thing, what do you reckon this is? So you've mentioned some good differentials. What do you reckon? Given that there's deep ulcers.
I would say...
Have a stab. Doesn't matter if you get it right or wrong.
Okay, I would say it's basically we look at the strictures because of which are because of the lye ingestion. So I'm thinking of if there's any corrosive intake, would it be because of any related to any lye ingestion?
Okay, all right. That's fine. Okay, and what would you do? What would be your next step for the management? What would you like to do to investigate further?
I would like to go for a CT esophagus with a CT scan with contrast.
Okay. Any other test you can do? CT?
Yeah, endoscopy.
Yeah, absolutely, endoscopy. Okay, so we'll call this one at a close. So basically, you've got this area, as you pointed out, of quite long area of ulceration. It's in the mid-esophagus. And the key thing here is that all these ulcerations are quite deep, okay? They go quite a fair bit beyond the contour of the esophagus. So you've got the esophageal wall here. you've got the smooth outline of the mucosa here, but then you've got all these projections into the wall. So these are deep ulcerations, they're confluent. This was actually inflammatory in nature. So this was Crohn's esophagitis, okay? Crohn's esophagitis is quite rare anyway. You don't get it that commonly in the esophagus. As you know, it tends to be more in the terminal ileum and the small bowel. But if you do get it in the esophagus, it's usually associated with small bowel disease. You gave some good differentials. Lye ingestion's definitely a differential. I think it tends to often be a bit more circumferential, but certainly it's definitely a differential. And I guess infection potentially, although again, probably not very common. You mentioned a kind of shaggy appearance. So yeah, I mean, I agree. I suppose maybe a plaque of candida could be a possibility here. Okay, thank you.
Okay, this is a one spot film from the barium swallow examination, little projection, a little oblique projection showing there is a crescentic indentation on the anterior wall of the esophagus with the smooth borders. No any other lesion is appreciated on the esophagus, and the rest of the barium, rest of the esophagus contour appear unremarkable. No any contrast outpouching or any abnormalities noted. So based on the finding, my differentials in this case includes esophageal leiomyoma or it's indentation. It could be it's a aberrant vessel.
Possibly, but I think it's a bit low for that. Yeah, you can see like one of the bronchi coursing off here. That's probably the left bronchus, isn't it?
Yes, okay.
A bit below that, it's more sort of mid-esophageal, isn't it? You can see like starting to taper off to the GOJ there. So do you want to just summarize your findings and then we can think about differentials?
My findings on, madam, it could be it's a smooth border. So it's one is my leiomyoma.
Okay.
And other is it could be some ulcer.
Yeah, good. Yeah, it might be the core.
And okay, and other differentials include it could be possibly carcinoma. So next, I recommend further endoscopic evaluation.
Yeah,
if this
I
is
agree. You probably need an upper GI endoscopy. Yeah. Is there anything else you might like to know about the patient clinically?
Patient's history, madam.
Yeah, history. Yeah, such as. Here you've got a solitary ulcer, haven't you? Yeah, you've got a solitary ulcer in the esophagus. So do you know of anything that can cause solitary ulcers that are quite large?
Solitary ulcer.
If I told you they were immunosuppressed, would that help at all?
Candidiasis. or
Looking like this, I don't think. Try again.
Immunocompromised esophageal ulcers. Madam, herpes encapsulated.
Good. Yes, herpes. Yes. So herpes is a possibility.
Yes.
Not in this case. Any other
Okay.
viral?
But there are, madam, small innumerable.
Sorry.
My connection is interrupted. Madam, in herpes, I think there are multiple tiny ulcers scattered in the entire esophagus.
I agree. I was just going to say that you're along the right line, but the herpes ulcers, I agree, they tend to be okay, and they tend to be smaller. Yes, agree. Any other viral agents you can think of that will give an appearance like this? Sir.
HIV ulcers.
Good.
Or
HIV, absolutely. So this case was actually CMV, okay, cytomegalovirus. However, on the Barium study,
cytomegalovirus.
Yes. But radiologically on the Barium, this is actually indistinguishable from HIV. Okay, so both CMV and HIV ulcers can look very similar. Yeah, they tend to be large, to be quite flat, as you described, solitary as well. They tend to be single, and you quite rightly mentioned that with herpes, they tend to be multiple. They tend to be smaller and a bit more punctate. Okay. Yeah.
Yes, madam. Yes, madam.
Okay. Thank you.
Okay. I'm provided with 2 spot images of the barium swallow study. And I can appreciate that in the first image, there is a relative dilatation of the esophagus with the mucosal granularity and irregularity. And I can see that there are multiple small fillings of the barium in small areas, giving target-like appearances within the mucosa. And in the second image, it is showing the gastroesophageal junction. And there is a small stricture is noted within the distal esophagus, along with the mucosal granularity. And a small outpouching is noted at the level of the gastroesophageal junction. However, there is no extra addition of the contrast. So, ma'am, there is mucosal irregularity and erosions, which are suggesting esophagitis. And my differential would be, it could be due to gastroesophageal reflux.
Yeah.
GERD.
Yeah.
And second one, ma'am, it can be any erosive esophagitis.
Yeah. Yeah. Possibly. Yeah. Good differential.
And
any other thing following on from what you said before about GERD and reflux? Any other thing that you tend to get in sort of in the lower esophagus, as you've mentioned?
Ma'am, there is a complication of the GERD, which is the Barrett esophagus, in which there is velvety appearance of the esophagus, the distal part.
Good. So, do you want to summarize findings and then tell me what you would do next?
Yes. Ma'am, the esophagus is dilated with mucosal granularity and irregularity, multiple erosions and small collections of the barium, giving it a velvety appearance and suggestive of the Barrett esophagus, which is the conversion of the columnar metaplasia of the normal squamous epithelium of the distal esophagus, and it will be confirmed by endoscopy and biopsy because it is increased incidence of the carcinoma.
Excellent, very good, well done. So, yeah, that's spot on. So, as you pointed out in the first, sorry, I'll just get my pointer. there's actually some arrows on this. I apologize because that's not my case.
Okay.
So you can see this, as you pointed out, this sort of target appearance, which is basically caused by sort of a round raised mound in the mucosa with a central pit, which is where the barium sort of sinks into, yeah, which gives this kind of target-like sort of ulceration sort of target appearance. And as you rightly pointed out on the second spot image, you've got narrowing of the lower esophagus. It's very well done. You pointed out a small defect there. That actually was a surgical defect, so we can ignore that. And the esophagus has got this sort of reticular, almost lace-like pattern in image B. Yeah, can you see this these kind of little round sort of filling defects and these little lines created by the barium? So it's almost like mucosal reticulation. So this was indeed Barrett's esophagus. Yeah, and you gave some good differentials: reflux esophagitis. You could also throw candidiasis in there as well, especially with the second picture. Yeah.
Yeah, ma'am.
Okay, brilliant. Thank you.
I'm presented with spot image of barium swallow double contrast study in which I'm able to appreciate that there appears to be multiple nodular filling defects are seen, giving some lace-like pattern and linear ulcerations within the mucosa of the esophagus with surrounding irregularity of the wall suggested of shaggy esophagus. So based on these findings, my provisional diagnosis is this is likely Candida esophagitis. Differential includes acanthosis, glycogen acanthosis. Further, I would go for endoscopic brushing to confirm my findings and correlate with the history of diabetes.
Yeah, very good. This was candidiasis, absolutely. And it's kind of, whenever anybody mentions the word sort of shaggy esophagus, it makes you sort of think of candidiasis, doesn't it? You've got these ill-defined, irregular contour of the mucosa on both sides. It's a little bit similar to the last one, but even more sort of ill-defined, yeah? All these kind of irregular linear ulcerations, as you very nicely described. There's all these little projections beyond the mucosal contour indicating these sort of very fine sort of ulcerations. And you gave a good differential. Glycogenic acanthosis is a differential. It's quite rare. You only really see it in the elderly, but it could present in a similar manner on the barium study to candidiasis. Another differential potentially could be herpes esophagitis. However, having said that, with herpes, the ulcers do tend to be more discrete and punctate. In this case, you know, they're very sort of ill-defined and almost kind of touching each other, very confluent, almost like a large sort of plaque-like area of abnormality. Okay, that's great. Thank you.
Okay, this is a single contrast barium examination of the esophagus, barium swallow examination.
54 years old for abdomen pelvis with IV only.
Hello?
And the clinical information is to rule out diverticulitis.
I think somebody needs to mute their microphone.
Yes, of course. Okay, I'm talking now. This is a single contrast barium swallow examination, AP projection, focused on the mid and the lower esophagus. I can see that the contrast has nicely opacified the mid and the lower esophagus. However, I can see that there is an abrupt narrowing of the distal esophagus, gastroesophageal junction. And this narrowing appears to be very smooth and in the form of bird beak or red tail-like appearance. I cannot see any shouldering, no contrast hold up is a bit of proximal esophageal dilatation is noted. However, there is no massive dilatation. I do not see any external compression or contrast extravasation. The contrast has managed to pass through into the stomach. So based on these findings, my diagnosis is achalasia cardia, and I would like to correlate this with the history of the patient. The history must be dysphagia, which has started initially to liquids and then to solid. And this diagnosis can be confirmed by esophageal manometry or endoscopy. And further, we can refer the patient for endoscopy, and CT scan can also be done in this case, which will show smooth concentric narrowing of the distal esophageal gastroesophageal junction without any surrounding infiltrative changes and lymphadenopathy. So my diagnosis in this case is achalasia cardia.
Okay, good. I'm just going to probe you a little bit more, if that's all right. So I think you've given a really good description there, and certainly the features are very suggestive of achalasia. Having said that, do you know how perhaps we can possibly differentiate between true achalasia from pseudo-achalasia? So achalasia due to a secondary cause. Do you know how on the barium study we could possibly differentiate that?
Yes, ma'am. If we are able to find any alternative cause, I mean, if we do not find any cause in the barium study, then we will label it as idiopathic or primary achalasia. Or if we are able to find any cause, for example, massive dilatation in case of scleroderma, or if there is any, for example, filling defect or shouldering or things like that, which can point towards any etiology, then we would label it as secondary achalasia.
Okay. So I guess what I was getting at actually is pseudoachalasia basically refers to malignant stricturing. Okay. And
Yep.
on the barium study, one way in which you can potentially differentiate between true achalasia and malignant stricture, i.e. pseudoachalasia, is that with true achalasia, if you're giving them a lot of contrast, and like on this image here, you can see there's quite a big contrast column, yeah? The esophagus is quite full with barium. What tends to happen is that over time, the hydrostatic pressure, because of the contrast column pushing against the lower esophageal sphincter, will overcome the tone of the lower esophageal sphincter. So what will happen is periodically the lower esophageal sphincter will open, yeah?
Yes.
And you'll get contrast passing through. If it was a malignant stricture, i.e. pseudoachalasia, that wouldn't happen. The sphincter would remain fixed because of the malignant infiltration. Yeah. You mentioned a CT scan. This patient in this case actually did have a CT. Do you want to comment on the CT?
Yes. Okay. This is a CT scan of the abdomen at the level of the gastroesophageal junction without IV contrast, but oral contrast has been given. I can see that there is a well-defined but ill-marginated sort of infiltrating hypodense mass at the level of the gastroesophageal junction, and the margins are ill-defined, and they are sort of infiltrating into surrounding structures. So this mass appears to be aggressive-looking mass, not that typical of achalasia.
Okay, so do you want to summarize your findings and then give me a final opinion?
So if we combine these two images together, then I will come up with the diagnosis of C. esophagus.
Good.
Yeah.
So this in fact was a case of pseudo achalasia. Yeah. This was due to malignant infiltration of the lower esophageal sphincter due to a mass at the gastric cardia, as you described. So it's interesting, isn't it? It's a very good case. I like this case because it illustrates that, you know, sometimes you can't be 100% certain that there isn't an underlying malignancy there. And as you quite rightly stated at the beginning, this person would need endoscopy, you know, just to make double sure that that isn't the case. Yeah?
Mm-hmm. Yeah, ma'am.
Yes, ma'am. This is the spot image of the double contrast barium meal provided to me at the level of the stomach, in which I can see that multiple filling defects. These are seen within the gastric and within the gastric lumen, and also there is inward drawing of the barium column along the lesser curvature at the mid zone. I can see some outpouchings and some underfilling of the barium lumen, gastric lumen from the barium with the barium. Also, along the pyloric region, the streak of contrast with some mucosal irregularity is seen passing towards the antral and duodenum region.
This? Are you
yes,
meaning
ma'am?
this? Yeah, don't worry about that. I think that's just the overlying duodenum coming around. So don't worry about that.
Okay. In my provisional diagnosis, I will say that these are ulcerations along the lesser curvature of the stomach.
Okay. What makes you say ulcer?
Inward drawing along the lesser curvature. The barium column is inward drawn.
Mm-hmm. Okay. So,
and
yeah, go on.
And some filling defects. These are seen widely scattered within the body of the stomach.
Okay. And what would you do next?
I will do endoscopy, of course.
Okay, right. So you think these are multiple ulcerations?
Yes, ma'am.
Okay, tell me, what features? Yeah, go on, sorry.
But I cannot appreciate mucosal folds of the stomach in this study at this image. The mucosal folds appears effaced to me.
Good, yeah, that's a very, very good observation. Absolutely agree with you. Tell me, what features on fluoroscopic studies do you look for with ulcers? What makes you know something is an ulcer?
Filling defect with the ulcer crater.
Yeah, indeed.
Yes, I'm filling defect with some ulcer crater and the contrast crater within it.
Good. So if you have an ulcer crater, what happens to the contrast in the picture?
It will not be filled.
It will fill, yeah? It will fill, because a crater is a dent, isn't it, by definition?
Crater will fill with contrast, but the surrounding will be radiolucent, and it is like a halo mound around it, ulcer mound.
Correct.
And within a contrast crater within it.
Absolutely. Spot on. So is this what you're seeing here?
Sorry, ma'am, I cannot see your pointer.
So is this so I totally agree with your description of how you define something as an ulcer on a fluoroscopic study. So my question to you is that what you're actually seeing here, or is it, do you still think these are ulcers?
Madam, I will say that these are, I cannot see crater ulcer. These filling defects might be the polyps.
Yeah, why do you say that? Tell me. Why are they polyps? You're right, they are polyps. But I want you to understand why they're polyps and not ulcers, yeah? Because if you look at this one, okay, as you very correctly pointed out right at the beginning, this is indenting the contour, isn't it, of the lesser curvature of the stomach in the gastric body, yeah? Do you agree?
Yes.
Yeah? You can't see the mucosa here. Why can't we see the mucosa?
Because it is invaded. It is invaded by the ulcer. That is the ulcer. What can I say? That is meniscus sign, Carmen's meniscus, because of its mural inflammation.
Okay, I'm going to stop you there. So what I was getting at is the mucosa is raised. Okay, so can you see my pointer?
Yes, ma'am. Now.
So this is mucosa here, yeah? You can see this white line. So it stops here. The mucosa carries on, but it's here, okay?
Yes, ma'am.
Yeah?
Yes, ma'am.
The mucosa is actually going around, and you can see this area here. The reason you're not seeing it there is because the mucosa is actually pushing into the lumen, yeah? So this is a polyp, not an ulcer, yeah?
Okay, fine. Right.
And similarly here as well. So you've got these filling defects, which are areas of elevation of the mucosa, yeah? And you're getting these little circles of barium around them, which is giving you this kind of circular filling defect appearance, okay?
Yes.
If I show you the next image, this is a CT image, okay, that's been put on lung windows. Talk to me about this image.
Ma'am, in this spot image, which is provided to me, in which I can see that there are smooth indentations along the walls of the stomach or intestine. I can see that it might be the small intestine.
It's the stomach.
Okay,
it's
fine.
Patient.
I guess these are the smooth indentations along the walls of the stomach, which are not filled with the contrast, which are not filled with air, and they are smooth lined. The lumen. Should I comment on the lumen over here on CT?
So this whole thing is the gastric lumen, isn't it? Yeah.
Yes, it appears smooth. However, the smooth indentations along the walls is apparent to me.
Yeah. So and where are they coming from? Where are they arising from? They're coming from the wall. Yeah.
Yes, ma'am.
So
indentation in the walls. Yes, ma'am.
Exactly. So these are, but this case basically illustrates multiple gastric polyps, okay, which are arising from the anterior and posterior walls of the stomach, as you can see on this kind of coned in image here, which is a CT image that's been put on lung windows just to illustrate these multiple sort of indentations or elevations of the gastric mucosa, which are the polyps. Yeah. And
just we will scrutinize it further study for intestine evaluation, colonic evaluation, and family history of the polyps, and then relate it according to the age of the patient. If it is a child, then also take the history of the mucosal pigmentation and skin pigmentation, and then we will regarding it define it into hematomatous polyps or adenomatous polyps. Then full workout should be done according.
Okay, good. Excellent. Yeah, good. I agree. That's how you would work them up, isn't it? To make sure they don't have any familial syndrome, or, you know, you'd want to do some genetics, like, you know, as you said, if they're young, do a workup of the rest of the GI tract.
Madam, the one which is appearing on the lesser curvature, it appears that it is indenting along it, like the one we see in the malignant ulcer, Carmen's meniscus cum, ma'am. This one, ma'am. Otherwise, all were appearing like the filling defects, but the one along the lesser curvature appears somehow ulcerative to me, ma'am. But there were no mucosal folds there. That's why I was got some confused.
Okay, but there's no filling. There's no crater, yeah, because the barium's not filling it.
Yes,
Yeah.
ma'am.